What I'm going to try and talk about for the next little while is the truth about the Canadian healthcare system and the Patient Protection and Affordable Care Act. But first you have to know a little about me. You heard a little about me. One of the important things to understand in offering the nostrum of the America's Affordable Health Choices Act is that Obama and his minions are like the king in Through the Looking Glass. When the king said, "I didn't say there was nothing better. I said there was nothing like it." And I think slowly Americans are catching on to the con, but it's a challenging con because the way the words come out, it sounds very enticing. Me, I was born, raised, and bred Canadian. I grew up in Toronto. It was a great city to grow up in. It was sort of a city that was a little bit backwards when I was born and sort of grew up in when I was young. And then it sort of evolved into a cosmopolitan city. And like all great Canadian things, it has slowly become second-rate. For a lot of reasons, predominantly because of social engineering. But I did receive my medical training in Canada. I did practice in Canada. I did receive my specialty certifications in Canada. As a former Canadian physician forced to practice socialized healthcare, however, I've seen this all before. I've also personally seen it at the Veterans Administration and in the Medicare system and in the Medicaid system that we have here. Bureaucrats do not care one iota about you or your health. A fundamental tenet you have to walk away with.
Keep going.
Are we good?
Yeah.
Okay. They simply lie and make stuff up to shove healthcare restrictions and denials down the throat of a captive group in the name of efficiency and cost control.
That's better.
Oh, perfect.
Good.
And blame their constituents for the harm that they create. The Canadian socialized healthcare system began as an idea back in the 1940s. The drive for universal access began in 1946. This was not something that came up overnight. This is something that had to work its way through the system. The concept was to create universal access. What they didn't realize is that eventually they'd create universal access to misery. The Canada Healthcare Act, which finally solidified the Canadian healthcare socialized system, came into full being in 1984. Started in 46 and eventually went through. I was part of that 1980s because that's when I finished my training and I started practice in Canada, in Toronto, and Ontario was the last bastion to not acquiesce fully to the Canadian Healthcare Act. And there were things that Canadian doctors were allowed to do that weren't part of this universal healthcare system. But in 1984, all of that became outlawed. Indeed, Canadian doctors, particularly in Toronto, went on a doctor's strike, if you can imagine such a thing. They actually left their offices all in white coats and marched up to the local parliament building, the provincial parliament buildings, and protested. That lasted a couple of days because, in the end, there was no acquiescence by the government to change anything. The Canadian Healthcare Act is based on 5 principles. The first principle it's based on is that it's going to be publicly administered, so that it's run by a public authority and that it's to be non-profit. Basically, when you reinterpret all of that, that becomes one thing: single payer. Nobody else can do that. The second principle it was prefaced on is comprehensiveness, meaning that it will cover all insured health services provided by hospitals, medical practitioners, and dentists. The third premise is that it be universal, or universality. In other words, all persons are covered the same, the ultimate collectivist concept. The fourth concept was portability, meaning that you can use your health insurance no matter what province you're in. And for those of you who aren't familiar with a province, it's like a state, except in Canada, they're big. So we have basically 10 provinces and a few territories, as opposed to 50 states. Finally, the fifth tenet was that healthcare be accessible, or accessibility. Now, I will quote and paraphrase what they mean by that. What they're talking about is reasonable access to insured services on uniform terms and conditions, unprecluded, unimpeded, either directly or indirectly, by charges, such as user charges or extra billing or balance billing, or other means such as age, health status, or financial considerations. Sounds really fantastic. It really does. I mean, you could sell people on this. It sounds like, this is great. We're going to get everything, and it's going to be just a Shangri-La. Let's talk about reality. In reality, it is not really about universality. Physicians don't set their rates, the government does. And it doesn't do it through any particular formula that's based upon need. It's done through a negotiation between the various medical associations and the government, depending on its budget. So it's done by parties that are removed from actually the doctor's office. They're all calculated, and that's it. You can't charge anything else. You can't receive anything else. It also covers some dental services. What doesn't it cover? Now, this is something that they don't really talk about. The Canadian healthcare system doesn't cover a lot of stuff, except variably to certain groups, such as seniors and children and some groups that are on social assistance programs. Prescription drugs aren't covered. Now, that's very interesting because you would think that everything would be covered. Well, prescription drugs aren't covered, and that comprises 10% of healthcare costs. Well, that's a good way to not include those costs in your budget by simply saying, we're not paying for it, you are. What does that mean? Well, there are consequences to that I will talk about. It doesn't cover medical equipment and appliances. Like what? Wheelchairs. You've all seen the wheelchair commercials. There's tons of them on television all the time. It costs me nothing. Absolutely nothing. That's what the guy says on the TV commercial. Why does he say that? Because Medicare pays for this. Medicare will pay for your wheelchair. And in Canada, it does not. You got to pay for it. Now, the cool thing about it is that here, because Medicare pays for it and Medicare sets a certain fee, then the wheelchair only costs so much. In Canada, because they don't pay for it and because they have a captive audience, when you need a wheelchair, you will pay, like one of those motorized scooters. You can buy that here for $600-700. In Canada, even though you have to pay for it, that same scooter is going to cost you $2,500. All right? And that's not the exchange rate between Canadian and American. In fact, the Canadian dollar is worth more. That's how great our economy is doing. Which is really scary to me. The Canadian healthcare system doesn't cover allied health professionals. What do I mean by allied health professionals? Non-hospital-based physical therapy. You want physical therapy outside of the hospital? Got to pay for it. You want to see a podiatrist? Got to pay for it. You want to see a chiropractor? Not covered. You need independent living help at home? Not covered. Indeed, the fallacy of comprehensiveness is profound. Only about 70% of healthcare costs are covered by the Canadian government. So really, it doesn't cover everything that they're trying to get you to believe that it does, and the con that they're selling you that will just cover everything. It doesn't cover everything because it can't. And it knows that it can't. Interestingly, in the United States, a little tidbit for you to know is that government currently pays for 45% of all healthcare costs through its various programs, like Medicare, Medicaid, Veterans, and the Children's Health Insurance Program, which is known as SHIP. So the American system is getting there. 45% of your healthcare costs is getting to a tipping point where almost half of healthcare is being paid for by government here already. In Canada, it's 70%. Just remember that. So we're not too far away already, and that's before Obamacare. The fallacy of access. It was one of the great things that was offered in the Canadian healthcare system, that you'll be able to get to a doctor whenever, wherever you need it. However, in Canada, you need a primary care physician to get into the system. That's your gatekeeper. Without a primary care physician, you can't access anything except through the emergency room. Big problem is that rationing of physicians is causing a shortage and a restriction upon where physicians can practice. In other words, there aren't as many family physicians as needed to service the population because the government won't allow you to open up shop and because the government won't pay for someone to open up shop because government pays your services. Now it is fee for service. You bill for the, just like here, you know, you see a patient on a visit, you bill the visit, but you bill the government. That's the only payer. And so that's it. You just have this back and forth. It's sort of the one payer system. So, not enough primary care physicians. Government decides where you can actually practice. If I wanted to open up a practice somewhere and say, I'm ready to open up a shop, I'll get an office, I'll rent the space out, I can't do that. Government decides where you can practice. It determines the ratios of what kind of doctors can open up in a geographic area and how many of them can be there. And you can't get a hospital appointment unless the government allows you to practice. It's a very tightly controlled system. And so the whole system can't be expanded because government dictates who can practice where and what. In addition, hospitals can't just open anywhere they want because they're totally dependent upon government for their fees and for their budgets. And because of that, hospitals aren't opening up left, right, and center based on need. To the contrary, hospitals, as you saw, and that's a truth, hospitals close units. They close wards, they close beds, they restrict complete access to services based solely upon costs, the budget. Is there enough money to actually fund running the unit? Is there enough money to fund running the floor? If not, it's closed. And then they calculate how long they're going to close it for until they make up the budget. Rationing is not only common to physicians and hospital beds and hospital wings and surgical suites, but also emergency rooms. Even though you heard a terrible story about someone demanding emergency services, emergency rooms close down. And it's not like you have walk-ins like we do here if you have sort of a semi-emergency where you might want to just take care of something without, utilizing the intensive services of an emergency room. No. Nope. The only place you can get emergency services are emergency rooms in hospitals, and they may or may not be open. If they're open, the likelihood of you being seen in a timely way is unfortunately super small because people stack up. There aren't enough people to see them, and there aren't enough wards that are open, so you can't move people from the emergency room to a hospital bed because there are no hospital beds. So it's like an airport when it gets really busy. They just stack up the gurneys, and people are just waiting and waiting, and they actually do die while waiting. That is a truth. Technology is also limited in its access, as you heard, and that's also a truth. CAT scans, MRIs, PET scanners. Again, government is the one who funds these things. If government funds these things, then it's government who decides how many you will have, and when they will be open, when they will be closed, how it will be staffed. And they are all restricted. The average time that it would take to get a CAT scan, maybe if you're lucky and you have a doctor who will order one, because your primary care physician will never order one. If you need a CAT scan for some reason, like you have something going on inside that you're complaining about, you'll go to the doctor who's the primary care doctor who'll say, you need to see the inside specialist. And then you'll have to wait. But the waiting time for the inside specialist will be 8 to 16 weeks. And then you'll have to wait another 4 to 8 weeks if the inside specialist decides to send you there, but it's not likely because the mentality is one of, let's do a few tests before then. So by the time you actually get the procedure you needed, you can easily wait 6 to 12 months for a simple CAT scan or an MRI. If you get one. It doesn't mean you will. Same with therapy. Radiotherapy is similarly restricted in its access. Infusion therapy, we have a wonderful medical age now where we have these incredible biologic treatments. In my specialty of rheumatology, we've had this incredible explosion of new therapeutic agents that are done by infusions and injections. Well, infusions will require a hospital in Canada, but you can't get into the infusion centers because the hospital won't have the staffing or the services available, let alone the fact that they probably won't allow you to get the drug. Crippling diseases still exist in Canada, even though they shouldn't. Indeed, the Supreme Court of Canada in June 2005, and the doctor was up there, Dr. Jacques Chahoury, who actually took on the system in the province of Quebec, French-Canadian, sued the province of Quebec, and the Supreme Court of Canada in Quebec decided there, quote, access to a waiting list is not access to health care, close quote. That's a profound statement for Canada. That is an amazing statement. It is a recognition and a resignation that the system is failed, and that creating lists of people and trying to create this kind of rationed access is a failure. And it did it on a very important principle. It did it, the decision that it came to, based upon the Quebec Charter of Human Rights and Freedoms. In other words, not getting health care is a human rights violation, according to them. Unfortunately, even though they said that, the decision was stayed, and nothing has happened since then to improve the healthcare system at all. I wonder why. Because the government runs the system. So what does Canadian healthcare really mean? Canadian healthcare is a government monopoly. It is a socialized, fascist, communist, central command system. Doctors and patients are criminals in this system. They're the bad people. Private insurance for covered services is illegal in Canada. You cannot buy it. It doesn't exist. Doctors who accept private payment for covered services are criminals who are fined, jailed, and stripped from their ability to ever practice medicine again for you. Nobody knows in Canada what your doctor is really worth. Nobody knows anymore. They blurred the line. It's just a job. But if you think that's bad, what about the patient? Well, patients are also devalued. You're a chart number. You're a commodity. You're not a person, because that's not relevant to the cost. That's not the issue. There's no personal care. You don't get attention. The care is dictated by a system, not by need. What happens in Canada in the long term when you keep going at it like this? Resignation and acceptance, because you have no other choice. So you accept the lesser system, and then when guys like Michael Moore go to Canada and say, are you happy with your system? Everybody says, yeah. But that's like going to Ethiopia and asking if you're happy with your loaf of bread. Everybody will be happy with what they have, because it could always be worse. But that's not a measure of the quality of the healthcare system that you get or anything else. Happiness is malleable. There have been lots of studies on happiness. We can be happy with nothing, if that need be, and we'll still say we're happy because we're still not dead. Happiness is a terrible measure. So when people come out and say Canadians are happy with their system, I have relatives in Canada. They go through that healthcare system. They say they're happy. I sit down and laugh. That's silly. You can't be happy when you get this, when I say we can get this, and then I can barely be happy. How do we reconcile that? Because happiness is a terrible measure. Don't use it. Don't believe it. It is not a good measure of what you get in terms of your healthcare system. It's a relative term, and it's dictated by time and circumstance. Most critically, the most critical issue in the Canadian healthcare system is that the doctor-patient relationship is severely disrupted. It is significantly interfered with and significantly devalued. And that relationship is the critical element of all healthcare. No matter what anybody says, The doctor-patient relationship is the key to your well-being when it comes to health. What happens in Canada as well? A doctor shortage. Canada has the second lowest doctor-patient ratio after, guess what country? Japan! Japan. Go figure, right? Japan. Because they accept in Japanese culture the fact that you can be sick. In cultures where it's acceptable, where you have to accept the consequences of whatever comes your way and humility and all that, if that becomes a cultural norm, it will exist. And you can keep cutting back. And that's what happens. And that's what happened in Canada. In Canada, you have to have, as I said, a primary care physician to get into the system. You can't get a specialist without a primary care referral because the specialist is punished. You can't call up and say, like we heard the story a little bit earlier, I want to see I sort of have a back thing going on, and you're a really good surgeon. I saw you on the internet, and I really want to come into your office. Okay, we can book you in at 3 o'clock this afternoon. Can you come in? That's here. In Canada, you can't do that. Hi, I want to see, have you seen your primary care physician? No? Well, you have to see your family physician. We can't see you. Why won't the doctor see them? Because the doctor won't get paid. Because without a referral that you can document and prove, you can't make this up. You have to prove, you have to get like handwriting stuff to you from your primary care physician to the specialist in order for you to see the specialist. And absent that, the specialist will not see because they won't get paid for the service they render. That's the kind of control they exert. So what does that create? You heard. Waiting lists. Long lists. The caps on fees and income are significant. Because when your income is capped as a provider, or when the fees are limited for a service, you're not going to provide them if you can't afford to pay for them. So in Canada, as I said, we have these global budgets. When doctors have billed to the maximum of what they're technically allowed to earn within their specialty and experience, etc., they don't get paid anymore. When you stop getting paid, you're not going to work. And they don't. They shut their office. So even if you had a doctor near the end of the year, that doctor may be around because they've earned what they had to and they're done. So caps are severe and significant. So they limit availability, they limit practice hours, and they limit access. What's the other consequence? Well, if you need a primary care physician to do things, you can't get your primary care physician and you get sick, where do you go? Only one place, the emergency room. That's the only place you can go in Canada. Like I said, there are no intermediate facilities like our walk-ins and stuff like that. So you end up in the emergency room. So as the emergency rooms fill, long wait times. You end up languishing in the emergency room, which does two things. One, you don't get better, but the real sick people, they get worse. So real emergencies can't be handled as they back up. And this is the substitute for absentee physician access. Another consequence of the Canadian healthcare system, reduced medical school sizes. After all, if you don't want a lot of doctors around, what better way than to stop them from actually getting into medical school? Good idea. So, less doctors graduating. Outcome of that, though, is a doctor shortage. Wow, what a surprise. So you can't get to see doctors. As a former Canadian physician, they beg me now to come back to Canada. They will pay me extra over Canadian physicians to come back because nobody wants to practice in my province of Ontario. I can make more than my colleagues just having left, so I can go back. The other consequence of that is that who ends up going to medical school? Well, people who are less interested. The less qualified candidates. After all, if you're really qualified and you're really smart, and I will tell you now, not to brag about me in particular, but the smartest people in society, the best trained, the most critical thinkers in society are doctors. Nobody has had more education in society than doctors, especially specialists. Okay? By the time you're finished school, most doctors are in their 30s. And they have been to school for 25 of those years. It's a long process. They're extremely highly skilled individuals. However, if you're that skilled, why would you bother if you can be something else, like a lawyer, or an engineer, or a politician? Anything could be better. Many things are. And so the best and the brightest don't go to medical school anymore. That has led to another consequence: increased numbers of foreign medical graduates who do the job the Canadians no longer want. Unfortunately, foreign medical graduates graduate with lower medical standards and have this constant focus on medical social justice. They help promote the system, and they don't know anything different. So they work to do what's good for society, so the patient becomes even less relevant. What does that lead to in the end? Part-time doctors. The number of part-time doctors in Canada is burgeoning. Why work full-time if you're going to end up taking the year off anyway? Doctors have 2 careers, particularly women doctors. It's nice. The women's lib movement has been very powerful in Canada. Lots of women doctors. They work part-time. You know, put in 20 hours a week, shut your door, you're not responsible for anybody, doesn't matter. It's not the kind of commitment that you expect out of doctors who make this a career. It's just a job. And then other doctors will do it part-time and have another career to do something else, run a business or do something else. We talked about doctors. What about nurses? Same problem. Huge nursing shortage. Who wants to be a nurse if you can't be guaranteed work? If you're busy shutting off hospital wards and you don't know if the emergency room is going to be open or closed, you don't know if the delivery room is going to be open or closed, you don't know if you're going to be working. So there's a nursing shortage in Canada as well. All of this is because of the rationing that occurs with limited access to doctors, specialists, treatments, hospital beds, and technology. The consequence of which is prolonged waiting times, progression of illness, progression of impairment, progression of disability, and increased costs to the healthcare and welfare system. The Canadian healthcare system is not a healthcare utopia, but rather a social, non-free market dystopia that fails in its fundamental underpinnings and punishes those stuck in the system who are not politically connected or wealthy enough to seek healthcare outside of Canada. The Canadian healthcare system and the American healthcare system are 2 extremes on the continuum. A tale of 2 systems, so to speak. The Canadian worst of systems, with denial, delay, and total lack of accountability. And the American, the best, but a wastefully abused system. What is the biggest healthcare expense, do you think, in our American healthcare system? What?
Medication.
Nope. Nope.
Bureaucracy.
Bureaucracy. That's right. In America, the largest healthcare expense is also the greatest source of waste. Bureaucracy, administration, and regulatory micromanagement. How much do you think that costs? What do you think? Any ballpark ideas as a percentage? Close. Pretty close. 1/3. 1/3 of our costs in our American healthcare system are due to bureaucracy, administration, and regulation.
That include the insurance companies, bureaucracy, or only the government?
Everybody. Everybody. It's all the same. It's still 1/3. Everybody.
Did you say bureaucracy?
Administration and regulatory micromanagement. Now, remember the number I gave you. I gave you a number, right? 16%, right? Remember that number? Let's take 1/3 off of that. When we take 1/3 off of that, what do we get? About 11%. What number did I give you for Canada? 10.1. Get rid of the bureaucracy, and we wouldn't cost anything more than Canada virtually. Except, we wouldn't be at all like Canada. because we wouldn't have all that limitation and restriction. Indeed, pretty much all socialized systems, of which almost all world health care is right now, runs between 8 to 10% of GDP. Just imagine getting rid of the bureaucracy alone and the regulation. So, now let's talk a little bit about the Patient Protection and Affordable Care Act, which I call an oxymoron. We call it Obamacare. So let's understand this a little bit, because to understand how to really reform the system, now we understood what Canada is all about. Let's understand a little bit about what America is about. What are the fallacies on which the Patient Protection and Affordable Care Act, PPACA, or Obamacare are premised on? The pressure to reshape healthcare in this country has been founded on 3 fallacies of crisis. First fallacy is the fallacy of the uninsured. According to the National Center for Health Statistics, the percentage of Americans under age 65 without health insurance in 1994 was 17.5%. In 2008, it was 16.5%. The percentage of uninsured people has not changed in all these decades. It is a lie when you are being told that there's an increasing percentage of uninsured. But they play a little game. They say there's an increasing number of uninsured, which is true because the population has grown, right? So 17.5% of 100 is 17.5, but 17.5% of 200 is 35. So yeah, there's more numbers, but the percentage hasn't changed one iota. The problem hasn't grown at all. The percentage of uninsured Americans has been relatively stable and unchanged for 25 years.
That's nothing.
Okay? Now, the real truth, if you really want to think about it, is that there are more insured Americans than ever in the history of this great country. Okay? That's the real number. The proportion of those who don't have health insurance versus those who do is virtually the same for the last quarter century. Now, if we look at the data a little bit closer, looking at things like the Kaiser Family Foundation and the National Institute of Healthcare Management, of those who are uninsured, of that group, okay, 25% of those actually qualify for public health programs already available, but they don't avail themselves of it for various reasons. 20% of that group, they can actually afford to buy health insurance, but don't want it or don't believe they need it. They make a choice. Another 25% of that group are illegal. They don't belong in this country. So, what's left over out of that number? 14 million legal American citizens and residents today who are really without health insurance, not by choice. Important fact, though, the uninsured population is in flux. What does that mean? It means that many, if not the majority of uninsured today, will not be uninsured a year from now. They keep changing. You know, it's just a matter of circumstance. Change in job, change in environment, but you get back to things again because our system actually does work. They'll be replaced with a new group, but with the same demographics. Ironically, okay, here's the real irony. According to the Congressional Budget Office, the PPACA, Obamacare, will still leave the majority of these individuals uninsured in the end of this all, estimating that 17 million uninsured individuals will still exist by 2019, of whom half are not legal residents. So it still doesn't solve the problem. No big surprise. The other fallacy of the uninsured is that they do not have access to health care. This is tacitly untrue. I'm in the system. Anybody in this country can get health care, even if you're not legal. Perhaps especially if you're not legal. The crisis of uninsured is a hoax. Yeah. The second fallacy is the fallacy of corporate greed. It's a favorite they like to sell for you, saying, it's the corporations, they're robbing you blind. This charge has been most strongly levied against pharmaceutical companies that provide life-saving and life-changing drugs that alter the face of disease and illness. Now, if you look at data from the CDC, the overall share of healthcare costs for medications has doubled since 1980. Okay, that's real, but we've got lots of new drugs. I remember when the PDR, the Physician's Desk Reference, was a book. It had a couple of columns. It had 12-point font. It was really big. Now, and it was like maybe 1,000 pages. Now it's 2,000 pages. It has 4 columns. You need a magnifying glass to read it. Tons of new medications, all of which have been amazing. They've changed the way we practice medicine. And how have they done that most profoundly? Because they've stopped you from getting sick and stopped you from accessing health care, such as hospitalization. For every dollar you spend on medications, you save $2 in hospital costs. The pharmaceutical industry has done wonders not only in producing life-saving things, health-creating things, but also has reduced healthcare costs by doing so. It's just that we've shifted it to a different place, so we see it a little bit differently. But you're not in the hospital. But who remembers that? It's revisionist history to think that people used to go to the hospital for everything. You have a headache? Come to the hospital for a few days. Lay back. We used to do that all the time. It was the thing you did. You put people in hospital. You didn't have anything else to do. So you'd sit there, you'd try a few things, you'd give them some IVs and hope things get better. And then we treated some real stuff. But now we can do so much more. And we don't need the hospitals. We don't need those costs. So this is very significant because hospital costs consume about 30% of healthcare dollars, but pharmaceuticals only consume, as we talked about 10% of healthcare dollars. So if we can double the rate of reduction of healthcare costs through increasing pharmaceuticals, that's a net gain, and that reduces costs tremendously. So the crisis of pharmaceutical corporate greed is another populist fraud. The third myth is that rapidly rising healthcare costs can actually be controlled by government. Since 1995, government healthcare programs such as Medicare, Medicaid, SHIP, which is the Children's Health Insurance Program, and the Veterans Administration have comprised, as I said, about 45% of healthcare expenditures. Yet, at no time in the last 14 years has any government program reduced the cost of health care one single iota, despite promises to do so. In fact, the costs in these health care programs and these public health care programs have risen at least as dramatically and usually at a far greater rate than private sector costs, according to the CDC. Furthermore, through government incompetence and imprudence, Medicare is projected to be bankrupt by 2017. This is no different than all other government social benefit programs, which are universally characterized by administrative waste, administrative fraud, corruption, social engineering, governmental conflict of interest, limitation or rationing of goods and services, and increasing costs for ever less services and products. It is foolish, if not downright delusional, to believe that perpetually unfulfilled promises of cost control speak louder than the actions of progressively higher costs and debt in all government health care programs. The proposals that have been offered in Washington to fix health care are premised on 5 stealth concepts. First, to provide health coverage to all, no matter what the real cost. That's the Canadian model. Second, control costs by controlling access to services and the availability of services. That's the Canadian model. Use regressive taxation and wealth distribution to subsidize governmental health care decisions. That's the Canadian model. Ration services by government-regulated decision-making. Well, heck, that's a Canadian and American model. And then, fifth, erode and eventually eliminate private or self-directed health care and health insurance. That's the concept. That's what's going to happen slowly but surely. Let's talk a little bit about why things went wrong in the American healthcare system, because that's important to understand, because we know there are problems in it. And let's also understand that, because then we'll understand how Obamacare not only doesn't fix these, but perpetuates them and makes them worse. So, what factors allowed the existing healthcare system to fall apart? 3 words. 3 words, the 3 most evil words foisted upon Americans in the existence of mankind. Reasonable and necessary. Nothing has done more harm than those 3 words, reasonable and necessary. These 3 words are embedded in each and every public and private insurance health contract. While that particular set of 3 words was not invoked a lot 10, 20 years ago, for those of us old enough to remember, you never heard that term. Who knew? Reasonable and necessary. You went to your doctor, you got paid, you needed a test, you got a test. Now everything, is it reasonable and necessary? We need to check. This has become the #1 weapon by which payment for healthcare services are denied. It's a trickery. The service, however, is never denied. They don't say you can't have the service. They just say they won't pay for it. Now, you have a contract. Any takers? You know, I never get a hand raised. It's amazing. Everybody knows this to be an untruth. Nobody can make your healthcare decisions better than you and your doctor. Yet your healthcare decisions are made by everybody but you and your doctor. The fact is, every insurance contract is not worth the paper it is written on if it allows the insurer the unfettered right to deny anything and everything it does not consider reasonable and necessary. Any insurance contract containing such terminology is essentially not really a contract at all, because it says that the insured is entitled to nothing other than what the public or private insurers deems appropriate. It's not a contract. You're a serf. The Lord will tell you what you get. And not that Lord. Nothing has done more harm to the doctor-patient relationship than these 3 words, as they are a blank check for public and private third parties to dictate services, medications, and other goods by holding patients and doctors hostage to reimbursement. In the world of private insurance, such denial falls upon the patients to pay. In the world of Medicare, such denials result in non-payment to the doctor or the supplier of services. What good is a contract whose terms are not defined and can be chosen to mean whatever one of the parties to the contract chooses at whim? That's your health care contract, and it doesn't matter if it's Medicare, Medicaid, or your private insurer. Second, health care insurance in this country has evolved from being insurance to a redistribution scheme. Health insurance has slipped out of the realm of concept of insurance that deals with non-routine contingencies. You know, like your car insurance. Your car insurance doesn't pay for car washes. It doesn't pay for oil changes. It doesn't pay for your gas. It doesn't pay for your tires. It pays for emergent contingencies, things that are unexpected, that could be expensive for you to have to take care of. Health insurance has gone out of that element and has become a program of wealth redistribution. Health insurers promise to pay for virtually everything and anything claimed, including routine expected visits, tests, and procedures, provided they deem it's reasonable and necessary. They do this the same way government provides benefits, by getting non-users to pay for the users. You're all familiar with that particular term, right? It's called racketeering, also known as a Ponzi scheme. Okay? That's what they're doing. No other insurance behaves this way. Car insurance doesn't behave this way. House insurance doesn't behave this way. They don't pay for painting, utilities. I'd like them to pay my utilities. Yard maintenance, clogged drains. True health insurance shouldn't pay for routine things or common conditions. That's not what insurance is. A redistribution scheme, on the other hand, is. As long as we do cover such routine items, we should be honest enough to not call such coverage insurance, but redistribution. Such a redistribution system leads to overuse and neglect of cost-benefit determinations, resulting in the kind of rationing of services, medications, and medical goods and limitations to access services that we see in Medicare, Medicaid, the SHIP program, VA, HMOs, and PPOs. That's the only direction it can go in. Third, the shielding effect of third-party insurance. Now you're sort of following me a little bit. Doesn't matter if it's government, doesn't matter if it's your private insurance, they're the same third party. Third parties, when they arbitrarily set payments and fees for medical services and goods and decide what to pay or not to pay, independent from the patient, the doctor, and the place and time of the actual provision of the services and goods, both healthcare providers and patients are shielded from the true value of the services and goods. You don't know what things cost you. You don't write a check. You have no idea when your doctor says get an MRI what that MRI bill is really. You have no idea what they're going to pay for either. All you know is you got it approved, it'll get done. Similarly, your doctor doesn't think about the cost. It's not coming out of your pocket. It's coming out of somebody else's pocket. And then the doctor says, well, you know what? I'm going to get this done just to be on the safe side because I don't want to get sued. Because he's not making the decision, you're not making the decision, someone else is deciding. So everybody has to sort of cover their ends. If to the doctor and the patient, the issue isn't cost. It's simply about what needs to be done to get the third party to cover payment. So that's what we spend all the time doing nowadays. We actually spend a lot of time trying to get payment or reimbursement because of those three words. Costs are thus not considered in routine medical decision making in this country, as health insurance is considered to be an unlimited resource. We're all shielded from the costs. Interestingly enough, out-of-pocket payments have dropped from 27% of healthcare expenditures to 15% of healthcare expenditures between 1980 through 2006. As the out-of-pocket costs, as what you pay from your pocket for services dropped, the utilization and demand for goods and services skyrocketed. Because you're not in control. They are. Fourth, common procedural terminology coding. This is something you're not familiar with. This is in the background for the healthcare providers. It's called CPT coding for short. It is the terminology that we use to determine how you get paid for services, because all services and goods get assigned a number, and all these numbers and letters that go to make up this particular good and service have a calculation behind them. There's a system that assigns a certain dollar value to it. It's the standardized terminology that translates the services and goods provided into a billable code that is recognized for payment by insurers. It is a fee-for-service system that is used to artificially, however, and arbitrarily set medical fees and prices, because the people who set the fees and prices are neither the doctor nor the patient. It's those third parties who have a completely different set of goals. Ultimately, the values for the codes are determined by unaccountable insurance committees that use these codes to capriciously manipulate and favor tests and services based upon the reimbursement assigned to the code. Let me give you some examples. The codes discourage prolonged office visits. If I wanted to see you for 60 minutes, I get paid less than if I see 4 patients for 15 minutes apiece. Does that make any sense? My time worth something different? No. They pay more per unit. They pay more per unit of time if I perform procedures versus spending evaluation and management time sorting out complex patient issues. In other words, if I do stuff to you, I'll get paid more than if I actually think about what's wrong with you and try to solve your problem. That's how the system is rigged. The coding is used to justify costly and unnecessary procedures and to deny cognitive evaluation and management services that could result in the avoidance of using those procedures. The same system causes a 1-cent Tylenol equivalent to be reimbursed for $10 in a hospital. Interestingly, despite the fact that we have this amazing world of technology, you know, when I bought my first computer, it was this big, bulky thing, and it had what's called a 386 processor in it, and it barely had a squeak of a hard drive in it, and you had to take these floppy disks and switch them in and out, and there would be no, you know, nice graphical user interface. It would be like a green screen with letters that flickered and gave you seizures and all this kind of stuff. All right, that was my first computer. Cost me $2,500, and I thought I had, wow, first kid on the block with a computer. Awesome. And of course that was cool because I was the first kid on the block to use the internet because I was at a university, and universities used internets long before everybody got to use it. So it was really sort of cool. You should see the internet then if you think, no, maybe not. In any case, $2,500, all right? I bought a computer a couple of months ago. I have this computer that I paid $500 for, 1/5 the cost. Blazing fast, high definition, stereo, games, doesn't need 500 cooling fans to keep the system cool and stuff like that. I can balance it on my finger, you know, like the basketball players spin the ball. I can do this, it's so light. Just amazing. Technology improves things and brings costs down. An MRI is a technological amazement, the things that it can do. And compared to when I bought my first computer to what MRIs can do now, incredible stuff. It has moved on with technology. An MRI costs more today than it did back then. Didn't go down in price. Why? Because the CPT system. Now, ironically, that's what they'll bill the insurance company. Then the insurance company will say it's not reasonable and necessary. Then you'll be stuck paying it. Guess what? They'll charge you full price. Had you not gone through your insurance company and come to me and said, hey, Dr. Sarkozi, you know, I'm not sure if I need the MRI, but if you think I do, is there a way to do that cheaper? Because I'm going to get stuck with the bill. I can get you that same MRI for $300. The same that the insurance company will deny at $2,000.
$4,000.
Or $4,000. Depends. So that's the problem. We have a very mixed up system, and the CPT system sets this and has put this into stone in a terrible way. We've lost free market pricing. We also have developed a differential pricing system. As I said, I can get you for cash what it is that they'll charge you for if your insurance company doesn't pay at 1/5 to 1/10 of what it would cost had you never gone through your insurance company. Because everybody prices things differently. The $10 Tylenol pill. Again, a differential price. You can buy that in the store for a penny, $10 if you go to the emergency room with a headache. Differential pricing and reimbursements are a significant problem. And that also relying on providers who pay more to subsidize the providers who pay less. So in other words, if some insurance is paying you at half the rate of what you should be paid, but then you can get some insurance companies to pay you at a better rate, then you charge a higher rate there, a lower rate there, and it sort of balances out. Sort of socialized charity. That shouldn't be. You are what you're worth. We shouldn't have this discrepant system because the system can be highly gamed. The same assessment, treatment, or test has been reimbursed by different insurers at vastly different rates, with the lowest rates run by government-run plans, ironically. They set the low bar. So this has led to various non-free market systems such as HMOs and PPOs. And they set fees for services that are contracted at rates that are negotiated by providers and insurers without any consideration, again, on the effect on patients or their health or their care. So what's the outcome of that? Rationing of services and care for those in lesser reimbursing plans like Medicaid, Medi-Cal, and Medicare. Why? 3 words. Reasonable and necessary. Incredible power. CPT coding does not reflect real market costs or value. It is gained by healthcare providers to optimize reimbursement for wrongly priced or denied services. They're abused by insurers to manipulate the real value of services billed to them, to deny payments, or worse, to accuse physicians of undertaking the waste, fraud, and abuse because the coding didn't fit the insurer's profile. In other words, I see lots of sick patients, chronically ill patients. I'm a rheumatologist. I see patients with chronic pain, chronic joint disease. They take time. If I constantly bill a high value, what's called a high value code, meaning basically I spend time so the code goes up in value, if I do that consistently, I don't have this kind of neat curve that they're looking for. I have a shifted curve. They come knocking on my door. They say, you know, this pattern is a fraudulent pattern because doctors don't do that. But my patients do that. Well, I'm sorry, that's not what our numbers tell us. This is how they create criminals in this country out of doctors who provide care. The CPT coding system inflates costs directly, devalues the services and procedures that would reduce these costs. It's created significant imbalances in what is needed versus what is provided. It's a system that worked when medicine was simpler and we didn't have much to do. Now it does not work anymore. The next problem, the fifth problem in our system, overregulation. As the health of this nation has changed, various regulatory agencies and government bodies created regulations and laws that created mandates that supplanted the decision-making encountered in the doctor-patient relationship. All of them have added unpaid administrative burdens on healthcare providers. We do just more and more paperwork for what we know we have to do, but we have no choice because they force it on you. None of these mandates have ever been shown to be cost beneficial or to improve healthcare outcomes. The main effect of these interventions has been to erode the power and value of the doctor-patient relationship by reducing individualized decision-making, encouraging defensive medicine that generates unnecessary testing and treatment, and putting patients at greater risk for interventions that may not only be necessary, that may only not be necessary, but may in fact be detrimental to the well-being of the patient. For example, pre-authorization. I'm sure all of you have been through some nightmare with pre-authorization. It's an incredible process. Has nothing to do with the patient, has nothing to do with me, has to do with how to kowtow to some administrator who has some kind of checklist or some kind of mood they're in that will make them decide yes or no. Furthermore, there's been a major push by academic elitists to establish practice guidelines, to force physicians to follow standardized protocols. I don't have standardized patients. I don't know how I can fit them into a standardized protocol. And these protocols are based on limited research data that in fact can't be generalized. This leaves the practicing physician like me in an ethical and legal conundrum of protecting the practice and doing what is in the patient's best interest, which may include not following a standardized protocol. Similarly, there's been a push for something called pay for performance. In this program, the physician is paid more if a specific protocol of intervention is successfully completed. Whether or not the interventions are actually needed is not relevant. As long as you get them done, you get more money. So this requires documentation, paperwork, administrative staff. Ridiculous, absurd. It's the doctor's job to get the patient better in the best way, no matter what. We're going to add a few more things just because? The doctor should be doing that anyway. Studies have shown that such pay-for-performance systems are actually gamed to maximize reimbursement and interfere with the doctor-patient relationship. So what I've been telling you, in other words, we already have in our current healthcare system here, in this great nation, we already have socialized medicine. It is run by a growing and burgeoning cadre of bureaucrats and administrators who decide what things cost, quite removed from the free market reality, who decide how much they're willing to reimburse for services, procedures, and treatments independent of the judgment of the patient or the doctor, who dictate regulation, the distribution and availability, who dictate by regulation the distribution and availability of healthcare resources, in other words, rationing, based on costs and not need. What services, procedures, and treatments will be covered, if they're covered at all. Who themselves are nothing more than tools, these administrators, by which government mandates, regulations, and dictates are passed on to their insured members, and who create a vast and growing jungle of administrative paperwork burden upon doctors and patients well outside the realm of the doctor-patient relationship, if you even have a relationship with your doctor. And these administrators game the system solely based on costs and budgets, independent of any doctor-patient decision-making. Obamacare does nothing to eliminate or reform any of these burdens and costs, and in fact uses the same failed strategies I have just outlined and the ones used in Canada to implement Obamacare. They are the same as our current system. Canada, America, they're the same. They're just run by different people. But they're still the same. They're third-party systems that have removed the doctor and the patient from the equation. Their greatest concern is costs. Their least concern is your physical, psychological, social, or financial well-being. What do we do? Well, the solution to healthcare is on one page. Not 2,400 pages, okay? One page. Want to hear it?
Yes. Yes.
All right. All right. Of the doctor-patient relationship. 2, the elimination of all, quote, reasonable and necessary, close quote, exclusions from all health insurance contracts. 3rd, elimination of the archaic and misused common procedural terminology fee system, which has been heavily abused and corrupted by payers and providers. 4, give each individual the money being spent for their health on their behalf by employers and the government back into their hands as a taxed advantage benefit. 5, full disclosure of reimbursement schedules and covered formulary medications, all of which cannot be reduced or eliminated during the life of an insurance contract. So you know what they're going to pay, and they're going to pay it. You know what medicines you can get and what you can't beforehand, not they decide what's reasonable and necessary. 6, universal availability of portable, affordable, competitive health insurance to all who want it, from any insurer in any state. 7, pre-existing conditions cannot preclude obtaining health insurance. 8, portability of insurance from state to state. You get sick, it goes with you. Nice around the world, but everywhere else around the world there's a social system, so it doesn't matter. Actually, it does, because if you go anywhere else in the world, they'll charge you an arm and a leg. Actually, they won't know what to charge you. I had a patient who resided here in California, but who had for some reason, a cottage in Canada. Beyond me why you would have a cottage in Canada. They didn't fish. So they would go to Canada, and they didn't have health insurance in Canada. So when they needed services, when they were away from me, they would go and see the local doctor. When they first went there, the doctor had no clue what to charge them. They didn't know what health care costs. It's what I've told you. They had no clue what to bill them. So the doctor billed them some amount, and she was laughing so hard when she told me the story. She said, "This is ridiculous. I could retire there and afford to pay all my health care because they don't know what health care really costs." All right. 9. Number 9. 8 was portability of insurance coverage. 9, protection from catastrophic financial consequences of disease. Your health insurance has to protect. That's what insurance really is. It's to stop you from being destroyed in a catastrophe. It's not to pay for everything. It's to protect you from being destroyed. 10, minimal opportunity for waste, fraud, abuse, and corruption by health insurers and providers through the accountability of patients paying market costs directly for services through a self-managed health savings account. 11, medical tort reform that recognizes that adverse outcomes from treatment decisions, medications, and medical devices are real, expected, and not necessarily someone's fault. Stuff happens. There are bad people who do bad things, but more often than not, stuff happens. Such a system reinforces that informed consent means the patient is obliged to accept the consequences of informed risk. If someone tells you you can die from this and you die, and then you come back and sue them, but you didn't tell me I was going to die like that, that's getting a little too much, and that just pushes the cost. And that would ensure that courts rely on what's called evidence-based medicine rather than on emotional junk science or social justice, both of which have pervaded our courtrooms. How can all this be done? Without cost, can be done very easily. All you have to really do is make that stuff the rule of the land. Not hard to do. Get rid of reasonable and necessary. Get rid of the CPT code. Make insurance contracts insurance and make them accountable for telling you that what they promise is what you're going to get. All of this can be easily done by changing the current healthcare payment system into a tax-exempt health savings account model in which every legal resident could participate. The money for healthcare is already in the system, okay? We don't get it. It's taken from us forcibly through taxes, by our employers. It's taken from us. What if we got it all back? What if the money in the healthcare system is given to you as an individual to invest a portion into a tax-sheltered account that is to be used for health care purposes only?
Yeah, that's correct. Yeah.
What if the remainder of that money is then used to purchase a high-deductible health insurance plan with catastrophic coverage that guarantees that you won't be bankrupt if you get really sick? That already exists. Obamacare actually outlaws that. Thus, in this system, initial costs of healthcare are paid at 100% out of the money invested into the HSA. You and the doctor will decide. You go to the doctor with a headache and say, "Doc, I got this headache. It's the worst headache I've had in 50 years. Terrible. It's awful." Doctor says, "Well, you know what? Just probably a bad headache day, probably not much, but you could have a severe bleed in your head and die tomorrow. I don't know. Maybe we should get an MRI." Okay, in the system that currently exists, you'll say, "Yeah, get me an MRI. I don't want to die from a bleed." You don't ask the doctor how much it costs, nothing. Doctor says, "Okay, I'm going to order the MRI." Doctor writes the order, you go. They say, "Oh, we need pre-authorization." Doctor says, "Patient has a bleed in the head." That doesn't say you have a headache, because you won't get it approved. It says you have a bleed in the head. Do you know what the most common diagnosis for an MRI of the head is? Normal. Almost all MRIs are normal. We're doing too many normal MRIs. Why? Because nobody knows what the cost is. The doctor doesn't know, you don't know. But if you had an HSA, okay, and you're writing the check for that first dollar, even when the insurance will eventually reimburse you, out of the savings account that's been tax protected, because you'll have money put away, that'll be really cool. So then you say, "Doc, all right, what does that MRI cost?" Now, in that system, the doctor will say, "Well, the MRI generally costs, maybe a couple of $1,000, but if you write the check, I know this MRI down the street, they'll give it to you for $300. Then you'll say, "Well, that's a pretty good deal, but my headache isn't that bad. Can we just see how the headache goes and I'll come back tomorrow?" That's what you'll do. I know it, because this is what happens in my practice all the time. Okay? You make decisions with your doctor. Now, you're not going to sue your doctor because your doctor said you're going to die from this, and this is what you need to do. But then you decided, you know what? In the way I see things, maybe I just exaggerated the headache a little bit. Maybe it's not so bad. We'll see. Okay? You make a decision. It's your decision. It's between you and your doctor. And the doctor will write in his note, discuss with patient, informed consent by the patient. Patient said did not want an MRI. You can't sue the doctor. Instantaneous tort reform. You're not going to go back. And you won't be bankrupt because this is money you banked already. This is money that's put away specifically for that purpose. Once you reach a predetermined threshold, say you've been using some money out of it, then a second phase kicks in, a typical insurance plan. You know, whatever insurance plan fits you and your financial needs, a 50-50, 80-20, whatever is best, you know. Then you sort of cost share between the insurance company, and then you work at that tier for a while if you need health care services. And then finally, once you reach a predetermined cap, a catastrophic health insurance plan takes over at 100%. And you are covered for every dollar cost, and that doesn't come out of your HSA anymore. That comes out of the insurance. It's a system that is so easy to implement. It is so effective, and costs disappear. Once you reach all that, all payments and negotiations for services are undertaken directly by the individual, and the health insurance reimburses the individuals. Now, you'll say, well, but there are people who are in dire need. What do? You know, people who have social circumstances that aren't working out. I can see a role for government. Government can be a safety net, but a real safety net, okay? Where some of those individuals may need some assistance. In that case, the government can provide vouchers. You keep the same HSA, the government simply provides a voucher for you to continue paying your premiums so that you can have your coverage. And once you get out of your situation, which hopefully should be the way, then you can resume where you left off. So, there is a small role, but, hang on one second. There is a small role, but it should be what it should be, minimal. Safety net. Finally, the last bit. All government-managed healthcare systems must eventually be phased out and replaced by a robust, consumer-directed, competitive free market health insurance system that would evolve. Because that's what would evolve. You wouldn't need Medicare anymore. We'd have to transition. It takes some time. This is not an overnight thing, but you have to have visionaries to look down the future to see what's good for a country that's been visionary. The greatest country in the existence of mankind does not have to go back. It needs to go forward. We can have that system. We can have it all because there is a way to do it. The money's there, the people are there, the system is there. We wouldn't do anything. It just takes a bit of time. You know, people close to Medicare, we're stuck. You're going to be stuck there. You know, just like the Ryan plan said. You're stuck. You're going to be there, and we got to honor that. But eventually, like my 23-year-old son, you know, my kids in their 20s, they need to put away the money now. If you put away $5,000 every year from age 20 to age 65, you'll have $1 million. That's a lot of money to have in an account, of which you'll never use it all because you'll have a catastrophic plan. And guess what? That money can be passed on to your future grandchildren. So, that's the beauty of it. It's your money, not theirs. What does this all mean then? Remember what we talked about earlier. Once you eliminate, because if you become the administrator, you don't need another third party. You get rid of all the bureaucrats, all the administrators. You are your own healthcare administrator. What does that save? 1/3. Means the same to everybody. Not everybody needs the MRI. Not everybody needs the CAT scan. Not everybody who has terminal cancer needs to have $500,000 worth of treatment in the last week of their life. Some people may want it. Some people don't. It's a decision that you get to make because you are in control with your healthcare providers. In addition, significant cost-saving tort reform evolves. Because when doctors and patients discuss benefits, risks, and costs without interference, then those decisions are established by them. They're ironclad. They're not being manipulated. It's direct. You have an agreement. And you're much less likely to get sued when you're on a one-to-one with someone than when you have a third party manipulating everybody. In addition, free market, countrywide competition by health insurers would force rates down and make available a much wider range of plans to suit the needs of individuals, not corporations, not government. So don't be fooled. Obamacare does not improve your health. It is based on false premises and fallacies. It suspends disbelief and creates a cognitive dissonance that would have you believe that doing more of the same in the hands of government bureaucrat lackeys who now run about half of the healthcare system will somehow be better than the corporate bureaucrat lackeys who run the other half. It is a true race to the bottom. It uses the guise of healthcare to take your wealth, your rights, and your body and place them in total control of government bureaucrats to do as they wish. It is time for us to start talking about real healthcare reform before it's too late. It is certainly much simpler than you think. And just like you heard up there, and that quote is from P.J. O'Rourke, if you think healthcare is expensive now, wait till you see what it costs when it's free. Thank you. The first point? The simple salute number one, removing third-party insurers. The first point was removing third-party insurers, government, lawyers, and bureaucrats from doctors' offices to ensure the sanctity and individuality of the doctor-patient relationship.
But in the end, you still want them to pay your bill, correct? No.
Who?
That third-party insurer.
No.
You want to do away with third-party.
No. The third-party insurer will pay you, not me. You pay me. The third party will reimburse you.
So I pay the $20,000 for the surgery for the surgeon, and then I get it from my insurance.
Right. So you get to negotiate the contract that works best.
And that's going to keep the insurance costs down?
Yes.
Because you're negotiating with a doctor.
Because you negotiate. Because when you get rid of all the other...
I care whether I pay you $20,000 for a surgery or $30,000 for a surgery, because I'm just going to get reimbursed anyway.
Well, you don't get...
You and I work a deal for $30,000 instead of $20,000.
Because you won't go to the doctor if your insurance plan says, I'll only reimburse $20,000. You have a contract and you
don't want them to determine that. That's up to you.
No,
not them.
There's 3 phases. The first phase is where you pay the out-of-pocket costs 100% through a health savings account. The second phase, right, so you understand. So you know, so the second phase is a typical insurance plan, which pays a certain percentage, and you can determine how much your insurance. You can get like Cadillac plans that will reimburse lots, or you can get lower end plans that reimburse little. You can choose the plan, and you will know because you will have that listed in your insurance agreement as to how much they will reimburse for services. And you will get to pick and choose which plan works best. Your plan may not reimburse.
But you don't want a contract that indicates how much they will pay.
Yes, you do.
You don't want one.
Yes, I don't mind, because I don't care. Because for me, I'm going to charge what I believe I'm worth to you, and you will pay me what I'm worth to you. It's like an agreement, you and I. The third parties are out of it. What you get reimbursed will be your decision based upon the kind of health insurance that you deem you need and what you're willing to purchase in a competitive market. The only time it's 100% is the catastrophic plans. But those kick in much later. Everything else in between is highly negotiable.
You need to help me find a good catastrophic reinsurer because you can't afford it.
Well, yeah.
Can you repeat the question?
I can't get enough to the employee to do the basic deductible and pay.
Well, no, you can't do it in this system. The question is how to find a catastrophic reinsurer. You can't do it in this system. This system is not open enough. There isn't enough insurance competition. The number of companies that actually do insurance in healthcare is getting less and less, and they're restricted by state. In a competitive system, that wouldn't be the case because there's tons of money in the system. You have to take it out of the administrator's hands and put it back into the system to work for your healthcare. You have to change the system to do that, though.
I got to renegotiate in 2 months.
I don't know I can help you in 2 months.
Jack? Hi, thank you very much for a wonderful presentation. I just wanted to perhaps restate something about basic insurance and to help this gentleman.